Morana koutou, ko Waiahau, ko te Pora Ehau taku ingoa, ko au te kaiwhakahaere mo te rōpū I roto I tēnei hohi pera, te rōpū hauora Māori, and ko au te kaiwhakahaere mō rātou. He mihi tino nui tēnei ki a koutou katoa, ko tai mai I raro I te maru o tēnei whare, o Otago I tēnei wā. Hari koa ki te kiti a koutou, I haere mai nei I tēnei ata ki te whiriwhiri kōrero mō te hauora o ngā mea katoa. So it's just a really good greeting to you all this morning. I'm the Māori manager of the hauora team over here. Also have been over at Burwood as well before I came here. So it's just a warm welcome to you all this morning. And, you know, it's lovely when we can all come together to share our skills around hauora, which is health for everybody, not just for Māori and Pacific, but it's for everybody. And we need to share our kōrero, talking about that. How does that work? All our skill bases bring us together to get the best outcome for all our people at the end of the day. So he tino mihi aroha tēnei ki a koutou, he tino mihi nui tēnei ki a koutou I tēnei ata. Harikoa me pai tō koutou haerenga mō tēnei rā, e pai ana ki te kiti a koe kāo I tēnei wā, he tākuta tino pai koe no te mea I te wā I mahi ahau I te hohi pera o Burwood, he tino pai tō mātou treaty partnership. So I'm just saying to Carl, when I worked over at Burwood with him, we had a good partnership. And true partnership, treaty partnership, is your skill base and our cultural base together the best outcome for our people. It's very simple. It's understanding those things, and it can work a miracle. It can work a miracle for the patient, yourself, and the team. And that's who we're there for. Culturally, we're there to help our patient, the whānau, our teams, to keep you culturally safe. It's a really big job. And we're answerable to our community. If I don't do a good job, they'll come in and say, it's time to go, get out of here. And I know that when I come into these roles, I know I'm not coming by myself. I've got a cloak of people that I'm having to carry with me to keep me grounded, but also to ensure that we work a really good partnership together. So this morning, as you share, please be aware you're sharing for everybody, and please be aware that you want to have the best outcome for not only yourselves, but the people that you are servicing. So before I go, I want to do a little karakia for you fellas. Okay. E pā, haere mai I wanganui a mātou I tēnei wā. Ho mai tō wairua tapu I ringa I nei kōrero mō tēnei rā, I runga I ēnei tangata. Ko ihu karaiti tō mātou kai whakaora. Father, this morning I just ask that you would come, be with us, whether we know it or not, but also just support us in our day and just let us be comfortable in the kōrero that will be done, but also to nourish us. In Jesus' mighty name, Amen. All right. So have a good day, guys. And yeah, thank you.
Kia ora te Pora. Right, welcome. So our first speaker today is Sachi Summerlee. So Sachi is a speech language therapist who has worked across the inpatient rehabilitation and acute hospital settings. She currently works in the acute stroke unit at Christchurch Hospital and is passionate about working with people experiencing swallowing and communication difficulties following stroke. Thank you, Sachi. No. Set up. Yeah, it's just because they can't see your slides.
Thank you. Yes, I have. Kia ora koutou. Can you hear me okay? Yeah, lovely. Oh, kia ora to everybody who's here in person and on Zoom. Thanks for the lovely introduction, Rose. So as Rose said, my name's Sachi. I'm a speech language therapist and I work on the acute stroke unit here at Christchurch Hospital. And I'm really pleased to be here sharing with you today about dysphagia. Okay, so I'm really lucky to work with a wonderful interdisciplinary team on the acute stroke unit, wonderful colleagues across allied health, nursing and medicine.
Sorry,
Okay.
they can't see the screen.
Oh, that's okay.
That's what I'm trying to get.
No worries. We'll get started in a minute.
Sorry, hopefully.
Fantastic. Thank you so much, Laura. So some of my special interests include working with acute stroke nurses for swallowing communication screening. I also really like instrumental assessment of swallowing, which I'll talk a little bit more about today. And just apart from dysphagia, I love supporting people with aphasia and other communication disorders. But today I'm here to talk about dysphagia. So I'd like to cover a few dysphagia-related topics today. So I'll start with a bit of a dysphagia refresher. And then I want to talk about thickened fluids and kind of ask the question, do we want to thicken fluids or not? And give a bit of an update on thickened fluids and also talk about the free water protocol. I'd like to talk about the importance of oral hygiene as it relates to dysphagia. I'll give a quick word on straws. Then I'm going to talk about food textures and the International Dysphagia Diet Standardization Initiative. Then I'm going to touch on neuroplasticity and the idea of swallowing practice before I finish talking about instrumental swallowing assessment and particularly fees. Okay, lovely. So we know that swallowing is actually a really complex process. Even before we start eating and drinking, we're preparing to swallow with our senses of sight and smell. And then our lips shut, sealing the food or the fluid inside. And we start to form a bolus using our lips, tongue, cheeks, hard palate and jaw. Then our tongue starts to move the food or the fluid back with a stripping motion. Our soft palate rises up, the epiglottis deflects, and the upper esophageal sphincter starts to open. All of the muscles and the pharynx contract, and at this point, airway protection should be in place to prevent aspiration. So as you can tell, a number of things are happening in a really short time frame. If you happen to have a coffee or a water or something with you, it might be interesting to take a sip and just think about the process that's happening. So as you're probably well aware, dysphagia is the medical term used to describe difficulty swallowing. It involves precise movements of numerous muscles for every swallow, and dysphagia can affect one or multiple of the phases of swallowing. It can have real impacts on day-to-day life and enjoyment of food and drink, which is so important to everybody really culturally and socially. So we know the incidence of dysphagia and stroke is high at around 40 to 50%, and up to 27% of patients with stroke-related dysphagia will have silent aspiration, meaning that they'll aspirate without a cough response. So I'd like to start with discussing thickened fluids and just giving a bit of context first. So thickened fluids have been used in the management of dysphagia for quite some time. The commonly accepted view has been that by flowing more slowly, thickened fluids improve bolus containment and reduce the risk of aspiration and cough distress, thereby improving safety and comfort. I want to say at the outset, before we discuss some of the drawbacks, that thickened fluids can remain a useful compensatory tool, ideally in the shorter term where possible, and especially when assessed using instrumental assessment. As speech language therapists, we historically worry a lot about aspiration, and we do everything we can to prevent it. However, some of our management approaches, like thickened fluids, can create other issues. So we've become increasingly aware of some reasons to critically evaluate our use of thickened fluids. The Royal College of Speech Language Therapists released a position statement and paper in 2023, stating that there is an absence of evidence that thickened fluids can reduce dysphagia-related complications, such as aspiration pneumonia, or that they improve health or quality of life outcomes. So that's a bit concerning for us. So let's now review some of the potential adverse effects of thickened fluids. So these include reduced fluid intake and dehydration, urinary tract infections, reduced health and social related quality of life. Thickened fluids can give a feeling of fullness, leading to reduced appetite. They can, as we know, have a really unpalatable taste and texture. They're nothing like drinking thin fluids. And they also can cause increased thirst. So when we consider these effects, we really need to weigh up the burden of thickened fluids versus the risk of aspirating, for example, plain water. So now I'd like to talk about the free water protocol. So the free water protocol is a recommendation that is used nationally and internationally and is a progressive area of speech language therapy. It's actually been around for quite some time, originating in the USA, and plenty of research completed since has supported its use. So, when this protocol is recommended by speech language therapists, typically patients who are otherwise nil by mouth are allowed water at any time, and people who are on oral diets tend to be permitted water in between meals, being unrestricted prior to and allowed again 30 minutes after meals. Alongside that, medication should typically not be given with that free water. The reason for that is that we want to ensure that if aspiration of water does occur, that food residues and medications aren't aspirated alongside it. On the free water protocol, stringent oral care should be provided, and the recommendations might vary just depending on the individual's factors. We also want to ensure that really clear education is given to the person and their family and whānau. So why water? Well, the aspiration of small amounts of water is considered relatively benign. That's because pure water contains less pathogenic bacteria than other fluids, so it's a bit better than aspirating coffee or a glass of Coke. And small amounts of water can be absorbed into the bloodstream via the lungs. Okay, showing on the screen now is a patient information handout that was developed here in Canterbury that we can now provide to people for whom a free water protocol might be suitable as part of their dysphagia management. It includes some of the benefits of free water and also outlines some of the potential risks. For example, free water might not be appropriate for somebody who coughs a lot and gets really distressed by it, but it can have really good benefits for others. Okay, so let's now talk about the prevention of aspiration pneumonia. So in order to prevent pneumonia, we really need to look beyond any single factor, such as dysphagia, and focus treatment on all relevant factors. Research looking at risk factors has shown that dysphagia was concluded to be an important risk factor for aspiration pneumonia, but generally not sufficient to cause pneumonia unless other risk factors are present as well. It would be easy to assume that dysphagia would be the main predictor for aspiration pneumonia, But in reality, the predictors are quite varied and they're not all under our control. They include the dependence for feeding, a dependence on oral cares, tube feeding, such as nasogastric tubes, the number of medications somebody might be on or the number of medical diagnoses they have, whether they're an active smoker, and the number of decayed teeth. So probably some of these risk factors look quite familiar to us with the people that we might be working with after stroke, so we need to consider that these could be quite prevalent. Great, so now let's focus on how we can improve one of the risk factors for aspiration pneumonia, and that's oral hygiene. As mentioned, poor oral health is a predictor for aspiration pneumonia, and research has shown a significant reduction in aspiration pneumonia rates with the introduction of a stringent oral hygiene regime. So there are interesting studies from Japan where there have been teams of dental hygienists basically visiting patients and completing really regular thorough oral cares, and that's resulted in significant reduction in aspiration pneumonia, which is really interesting. So as much as we're able, we should focus on improving and maintaining the oral health of the people that we're caring for to reduce that risk of complications. So this might include really frequent oral cares using mouth swabs or toothbrushing. And whether you'd use a mouth swab or toothbrushing might depend on a few different factors. It's good to think about whether the person has the oral control to rinse and spit out toothpaste after brushing, for example. Okay, so let's move on to briefly touch on straws. Whether to use a straw is quite a common query for people with dysphagia after stroke, and they really can be beneficial or detrimental. They can be really helpful to control the liquid entering the mouth, especially for people who are just experiencing like an isolated problem with liquid leaking out the front and they're having difficulty kind of containing the fluid in their mouth. Straws can be fantastic for that. However, straws can also result in the liquid flowing really quickly through the mouth and then giving less time to prepare to swallow and increasing the risk of aspiration. So for somebody with those risk factors, they tend to be more detrimental. So straws are best used once the dysphagia, the nature of it has been established, and probably best when recommended by speech language therapy after an assessment. Okay, let's now talk about food. So modifying food texture continues to be a really widely used tool for speech language therapists when compensating for dysphagia. And modified food texture can be really helpful for both oral and pharyngeal dysphagia. For the oral phase, it's really helpful to reduce the requirement to chew really heavy textures if you've got weakness in those oral muscles. And pharyngeal phase dysphagia, having a modified texture can reduce the amount of residues that you might have in the throat after swallowing. So you could consider modifying food texture for a period for somebody with dysphagia, a little bit like recommending the use of a stick or a frame for somebody who's having difficulties with their mobility. It's a good compensatory strategy. So the International Dysphagia Diet Standardization Initiative, or the IDSI, is a globally standardized framework, and it describes all of the textures of food and drink. And if you work in for Te Whatu here in Canterbury, you'll be familiar with it because it's the textures that we use. Okay, so the graphic that's up on the screen now, it looks a bit overwhelming when you first look at it, but it shows all of the standardized food and drink textures that are included under the IDSI. So for example, puree texture food there in the green, it might be suitable as a starting texture for somebody who's got oral phase dysphagia or pharyngeal dysphagia after a stroke. But with ongoing care and assessment, it's quite reasonable to expect that somebody would be able to progress up through the food textures and return to regular texture if that's their goal. Great. So now that we've discussed a range of ways to compensate for dysphagia and reduce complications, I'd like to talk about how to improve it. So the principles of neuroplasticity would suggest that swallowing practice is really important for recovery. Therefore, it's timely screening and assessment of swallowing is really vital. We don't want people who are nil by mouth with dysphagia to be nil by mouth for a prolonged period. That's not going to help their recovery. So depending on the dysphagia, rehab exercises might focus on muscle strengthening, skill training, or even just swallowing practice. Within the world of skill training, there are evolving therapies that target swallowing skills. So biofeedback can be used to get somebody to improve the timing of their swallow or how strongly they swallow. And there are clinical trials related to swallow skill training that are happening here in Waitaha and nationally, which is really exciting. Swallowing practice might include a speech language therapist visiting somebody at intervals during the day and just giving small amounts of food and fluid to somebody who might be otherwise nil by mouth, just to have that practice and kind of be rewiring those swallowing pathways. So I referred earlier to instrumental swallowing assessment, and I'll just expand a little bit on it now. So when we talk about instrumental swallowing assessments, we're referring to video fluoroscopic swallowing studies, or VFS, which might be familiar to many of you. And as well as that, we look at flexible endoscopic evaluation of swallowing, or a FEES. Just the people who are here in the room, have many people seen a FEES before? Just raise your hand if you've seen it. Cool, great, that's good. So both assessments provide SLTs with a really vital look inside. I think with dysphagia, it tends to be less visible externally, especially for somebody who isn't showing really obvious signs of struggling or coughing. So it's one of those more hidden stroke symptoms. So these assessments are so helpful for us to have a look inside and give the person who's experiencing it, as well as the wider IDT, a really clear idea of what's happening. Okay, so on the screen now is just a still image of a VFS. And yeah, this might be very familiar to many people because it's been in the SLT toolkit for many years now. So a VFS is a moving X-ray, and we do it in a radiology department. It assesses swallowing physiology and safety, and it includes the oral phase, which is really helpful, down to the pharyngeal phase, and it can also include an assessment of the esophageal phase, so it's quite comprehensive. FEES, on the other hand, really focuses on the pharyngeal phase of swallowing, and it involves passing a flexible endoscope through the nostril and allows for a view of the pharynx and the vocal folds. So you're kind of looking down on the vocal folds when you do a FEES. FEES allows an assessment of anatomy, which is really helpful, and its impact on swallowing. And it also can look at food, drinks, and saliva, which is great. We can't really assess how somebody's managing their saliva on a video fluoroscopy. So a FEES is really helpful to look at whether or not saliva is pooling. Okay, so the picture on the left there shows kind of where the scope sits during a FEES. So you can see that kind of thin black line that's passing through the nose and with a wee light on the end kind of looking down at the vocal folds. The picture on the right shows me practicing on a colleague a few years ago, and I really think she looks surprisingly pleased to be practiced on, which was great, very willing participant. So FEES has lots of benefits in stroke. We do receive a really high volume of referrals for people who are nil by mouth, and a good proportion of those people will need an instrumental assessment prior to commencing oral intake. VFS clinics here in Burwood and many places tend to be at set times of the day because we're working with staff in radiology, whereas FEES can be completed at the bedside at any time, which makes it really flexible and something that we can do at 3 o'clock on a Friday, which is really great. FEES is really good for people who are on bed rest after acute stroke interventions like thrombolysis. So those people who aren't able to get up and out of bed and come down to radiology, they still have an option to have an instrumental swallowing assessment. It's really repeatable and it doesn't have any radiation exposure, and you can use it for as long as you like or as long as it's tolerated. You could, in theory, assess a whole meal if you wanted to, whereas with the radiation exposure involved in a VFS, you're going to be cutting that time down to make it as short as possible. So I've got a wee video now that I'll play. It's about 90 seconds long, and it will just give you a bit of an idea of what we're seeing when we're doing a FEES. And hopefully, I mean, I know for me, when we started using FEES, it was a whole new appreciation of how the swallow worked, because it's such a different point of view from a video fluoroscopy, and it's very different from looking from the outside. So I'll press play, and I can talk to you a little bit about it as it plays. So we're kind of looking down at the vocal folds there. You can see that kind of V shape. And that sort of, I'll use my mouse and see if I can point to it. Just here is the epiglottis, so that's what should kind of fold over to protect the airway when we swallow. And in the back here, which looks very kind of brightly lit, is a nasogastric tube, so we can kind of see that going down through the upper esophageal sphincter. So that was a swallow just then. And now we can see like quite a lot of residue there. You might be wondering about the bright colours. So we add like blue or green food dye to the food textures so that it's very clear which food is causing what kind of residues. With a normal swallow, we should see like almost a complete whiteout when the swallow happens. Like you can't see anything at all because the pharynx is really contracting strongly. So you can see quite a bit of green residue kind of sitting. Sorry, it's always tricky when someone swallows. There's a little bit down here, which, you know, ideally wouldn't be there. And we can still see some blue sitting in this space here and some green over here. So quite a lot of post-swallow residue. But we haven't seen any aspiration here, which is great. We would see like a blue or green colouring around where you could see the vocal folds, and that's where we would think the material's kind of getting towards the airway. So yeah, that's what a FEES looks like. Oop, we won't watch it again. Probably one time was enough. All right. So as I wrap up, I'd just like to review some of what I hope will be helpful kind of messages to take back to your everyday work. I'd like us to consider those predictors of aspiration pneumonia and the importance of oral hygiene. That's one of those kind of predictors that we can really help to control. Thickened fluid shouldn't really be considered a go-to like it used to be, and it should only really be used when it's been really thoroughly assessed as the right option, and preferably using instrumental assessment. And prompt assessment of dysphagia post-stroke is really important. We don't want people to be nil by mouth for too long. We really want to promote their return to oral intake and their recovery. Great. So yeah, whatever your role is in stroke care, thanks for all of your efforts related to dysphagia management, because it really is everybody's job and everybody's got a part to play. So yeah, thank you very much.
Wonderful. Thank you, Sachi. Do we have any questions from the audience? We've got a microphone here that Carl can take up to you. Yes. Yeah.
I'll get my ex.
Kia ora, thank you, Sachi. My name is Jessie. I'm an aged care physio, and I'm just wondering if you could give us the latest in terms of positioning, because we're forever saying to caregivers you must sit someone up for meals, and then also if someone's in a tilt and space wheelchair, how many minutes afterwards, after a meal, can we allow them to be tilted back again?
Yeah, that's a really good question, and I didn't mention it in my presentation, but positioning is so important for anybody really, but particularly if you have dysphagia. So we tend to suggest that somebody's sitting like 90 degrees upright in whatever chair they happen to be in, and that can take some creativity sometimes with different supports and things to get people as upright as possible. And especially positioning in bed can be really challenging when somebody's in hospital or in aged residential care. So 90 degrees really is the ideal. And I think we see more difficulties as soon as anybody is kind of reclined any more than that. Remind me of the other part of the question. Oh, yes. Yep. That's a really good question too. I mean, we tend to have a bit of a general recommendation to kind of wait 20 to 30 minutes sitting upright, just to ensure that if somebody was experiencing reflux or they've got post-swallow residues in their throat, that if they're kind of laid back immediately, that they aren't easily kind of tipped into the airway and aspirated. So yeah, I think that'd be the best suggestions. That's all right.
Kia ora. I'm Catherine. I work at Dunstan Hospital in Central Otago,
Hi.
where we don't have access to video fluoroscopy. So, and for other people in the room who work rurally, how do you recommend, like, are our patients more likely to get thickened fluids because we will struggle to assess that? Or do you think we should be transferring patients down to Dunedin 3 hours away?
Yeah, it's a really good question. And I totally acknowledge that I'm talking from like with a big hospital lens where we have, you know, the access to video fluoroscopy and fees. And it's very easy for me to say that it's great to have these assessments because they're so accessible here. So I totally acknowledge that that is not the case everywhere around the country, and there's a lot of variation. I think even without instrumental assessment, that speech language therapists using free water is a great option. We know that thickened fluids are actually more likely to be silently aspirated than thin fluids. So although earlier in my career, kind of before we had more of that knowledge, I used to quite routinely assess thickened fluids at the bedside. I would tend to stay away from that now because of my knowledge about silent aspiration of thickened fluids. So even if your only option is to assess at bedside, free water is a great option to try and avoid thickened fluids where possible. But I don't want to completely say no one should ever use thickened fluids again, because I do think that they have a place. So I hope that kind of answers the question.
Can I ask a question? It's a little bit probably out of what you've talked, but my understanding is that there might be some more studies or protocols coming out for what to do before a speech and language therapist is available to assess a patient. So for example, over a weekend when you can't get a speech and language therapy assessment, and whether we might at some stage move to free water for some patients before SLT review.
Yeah, I mean, that's a really...
Assuming obviously that they've not passed the nursing swallow.
Yeah, that's a really good question. And I wonder whether maybe that is somewhere we go in the future if we continue to not have, you know, weekend access to speech language therapy. Obviously here at Christchurch, for those patients who come in with an acute stroke, we're really fortunate over the weekend to have access to acute stroke swallow screening from the wonderful stroke nurses, some of whom are here. Which I think really kind of fills at least part of that gap, because they're having a general look and getting those people who are normal to start eating and drinking. But it definitely could be something for us to look into in the future.
Hello, another aged care physio here.
Oh.
Just further to the positioning question, I often see residents in aged care sort of with their head and neck extended a bit as a general sort of positioning. And I've often been talking to the caregivers and nursing staff about just making sure there's a slight chin tuck going on. And I just was swallowing. And I just wanted to make sure that that's still what's recommended for them to sort of just verbally cue them to do so. Because many can do it if they're cued, but often I see the head and neck extended with a swallow, and that really concerns me sometimes.
Yes, yeah, totally. I think as much as we can, we want to just encourage that really kind of neutral position, and probably a slight tuck is definitely better than like an extension. Because if you imagine, if you put your head back like that, your airway is much more open. So a chin tuck actually is a compensatory strategy that can be like prescribed by speech language therapists for specific people, but just generally I'd recommend a nice neutral position as much as possible is definitely preferable over the head extension back. Yeah.
Wonderful. Thank you, Sachi. That was a really informative talk. We enjoyed that.
Well, thank you
And
so
here's a little
much.
thank you
Oh, thanks, Rosie. It's really nice.
for speaking today. Okay, so we've had a little rearrange of the program due to some delayed flights. So next up we'll have Continence After Stroke by Nicky and Jacqui. So a bit about them. So Nicky has been working in neurological rehabilitation for the past 20 years, both in the UK and New Zealand, in the acute and subacute settings. She has been in the Community Stroke Rehabilitation Service here in Christchurch for the past 10 years. And outside of work, she is a busy mum and taxi driver to 3 children. We also have Jacqui here. Jacqui has worked in the Community Stroke Rehabilitation Service for Health NZ as a physiotherapist for the last 10 years. Prior to that, she spent 10 years in a variety of older persons' health rehabilitation wards at Princess Margaret Hospital. Outside of work, Jacqui is kept busy with her 3 sons and enjoys a small amount of time she gets to fill her cup doing Latin dancing. So thank you.
Kia ora, I'm Nicky, and this one's Jacqui. Turn it on. Is that better? Yeah. So we're here to talk about bladder management today post-stroke. As the introduction said, we're both from the Community Stroke Service here with Te Whakatau. We're very fortunate. We work part of a very supportive IDT team. We have social workers, speech language therapists, registered nurse, physios, OTs, allied health assistants and doctors are all part of our team. How do I just click? Okay. This here's a quote that our RM brought back from one of her study days that really resonated with her and with us. So urinary continence is not a diagnosis, it's a symptom that something is wrong. The cause is unknown, the client deserves a full assessment and diagnosis. Aging or being female are not on their own a cause of urinary incontinence. Quite often when we're in the community, we hear patients say, are very dismissive of their symptoms and saying, oh, I'm just old or I'm just female, and it's educating them that actually that on itself is not a cause. Jacqui and I have been on a bit of a journey over the last year. We've been trying to work out how we can further support our RN with our service. Traditionally, what happened is anyone who experienced urinary incontinence was referred on to our lovely nurse who went ahead and did all the management. Jacqui and I wanted to work out how we could help support her better and also incorporate more of a rehabilitation approach into the management of it. Why did we want to do this? Urinary incontinence is quite a common problem post-stroke. The incidence varies in the literature from about 30 to 60%. So it can be a new problem, or if it's pre-existing, it can be significantly worsened. Urinary incontinence, as I said before, the assessment of it has primarily been a nursing role, but the current stroke guidelines actually recommend that physios are involved in the management of it. So what have been some of the barriers to why we haven't been involved? There has been some research conducted in New Zealand that went out to New Zealand physios, and it indicated that physios in New Zealand considered that a lack of formal training and uncertainty about their role in urinary incontinence rehabilitation limited their involvement. And that was certainly consistent with the results I found within our team when we did a survey of the physios. Jean Hay-Smith actually from this has gone on and done some further research with some of her colleagues, which was presented at last year's study day. That research hasn't yet been published yet, but when we had a discussion with her, she was saying that the research involved getting a stroke patient's perspective of the continence management that they experienced, and what they wanted was caring conversations. So conversations around incontinence, around potential management options. They may not necessarily rate it as an important thing at that point in time to be managed, but they wanted to know and be aware of what's out there, and particularly discussions around social continence. So not just continence at the home, continence being able to manage and get out socially. Within our service, as I said before, we're an IDT service. Any new referrals that come in have either been seen in the hospital, discharged, or a GP's. Any one of our team members can be going out to do the initial assessment.
So when we did a bit of an audit of what was happening, we found that we weren't consistently asking about it, or we weren't documenting that we were consistently asking about incontinence. And when we surveyed our staff, again, it was sort of similar themes coming through, that a lack of knowledge, a lack of confidence with what to do about management, a lack of understanding of the different types of incontinence, and who to refer on to if needed, were sort of all barriers to why it wasn't always being asked. So Jacqui and I have gone on and done a bit of learning ourselves. We are certainly not experts in this area. We are a couple of therapists who just wanted to find out more information about how we could better support our patients. We went and spoke with the women's health specialists and advanced practitioners, and developed a bit of an education package that we gave to our staff and the wider community services team here within Te Whakatau. So we're going to give you a brief overview of that today. So just very quickly, understanding the normal bladder and what happens. So there's two functions of the bladder. It's for storage and micturition or voiding. So to be able to store, you need to get relaxation of the detrusor muscle. And that's supported by the urethral sphincter and the pelvic floor muscles down the bottom. So they all need to work together to achieve storage, and then the detrusor muscle needs to relax alongside the relaxation of the sphincter and the pelvic floor to be able to void. It's normal to pass urine every 3 to 4 hours and without experiencing urgency. On top of just the muscle control, you've got the neurological control. So just find my notes. The normal control relies on the coordination of the bladder, the pelvic floor, the urethral sphincter, the spinal cord and the brain. So we've got 3 levels of high neurological control. You've got the spinal center, which is relaying all the incoming and outgoing sensory nerves and motor nerve impulses. You've got the pontine center, which is your switch between storage and voiding. So obviously a stroke in this area can cause issues. And then you've got the cerebral cortex, which is your inhibition. So the bladder muscle relaxes, starts to store. Once it gets to about 150 to 200 mils is when you start to get the stretch receptors in the muscle actually sending signals up to the brain to say, oh, we're getting to the point that we're needing to void. So you can then come back down through the inhibition to actually allow that social convenient voiding, that you don't have that urgency to go then and there. So obviously with speaking of that, if there's a stroke, then actually that can inhibit that or make that challenging. So where do we start when we sit with a patient in front of us? We start with questions, and we start using lay terms and asking them about their toileting, what's happening for them, both daytime and nighttime. How often are they needing to go? Are they making it in time? Are they needing to use products? Is it different to the way that it was before the stroke? So you want to get a general outline of what's happening for them, and then you want to delve a wee bit deeper to kind of figure out what type of incontinence is happening. So is it that they're too slow getting to the toilet? Is it that they're having difficulty getting their pants up and down? Is it that they can't communicate that they want to go? So is it from the impairment aspects or the functional aspects that have happened to them following the stroke? Are they getting little warning? So are they getting urgency, or are they needing to go a lot more often, a lot more frequently? Or are they having difficulty initiating the flow? So they're getting to the toilet and they're having trouble going. Or the other side of that is that they've been and then they get up and go and they're still having some leakage afterwards. So that's more the retention. Is it when they cough or sneeze, lift or strain? So to help our team, Jacqui and I developed sort of a bit of a screening chart. So it's got, this here will be in your slides. I assume everyone gets a copy of this. So it's about all the questions to ask to try and help
clarify sort of what's going on for them or what type of incontinence they're getting. And then following that, to help the staff that don't deal with incontinence a lot, what to do and who to refer on to. The general handout that's in there is one that we use from the Incontinence New Zealand, and it's on their website, but it's specific to stroke, and it has some really good information about food, fluid, and other stuff in there too. So for those that then we're wanting to get involved more in a rehabilitation approach for a management, this here is specifically for us physios or OTs if they want to be involved in it. Some of our OTs felt that they were confident to be part of this too. It's to help guide our management strategy. So this is all the different types of incontinence and then how we can go on and management strategies or options around that. So Jacqui's going to go through these now, each separate one, and talk about each one separately.
Yeah, so with only having still 30 minutes, we can't talk about all the issues in detail. So we'll just go over some. Do I just Okay, so one of the issues that people can have after stroke is retention of urine within the bladder. That could be acute or it could be chronic. So for the acute ones, it's where suddenly people are unable to pass urine. There could be quite a bit of pain with that in the abdomen. They may also find that if the bladder's filled up far enough that the abdomen will actually be distended. This is a medical emergency, not something we can help with as allied health. So need to refer them to a doctor straight away. Possible complications of this is that if it keeps filling up, urine can flow back into the kidneys and cause damage. Also, the bladder is a muscle, so if it gets really, really stretched, once the bladder is drained, and potentially if the person goes on to have a trial avoid removal of the catheter, it impacts on the ability of the bladder to contract and fully empty afterwards. So really important to get onto that quite quickly. Well, I've gone too many. How do I go back on this? Back button on here. Sorry. The other type of urinary retention is chronic urinary retention. And so this is where just over time the bladder isn't emptying properly each time. And you can end up having more and more post-void residual in the bladder. So some signs and symptoms that people might be having difficulty with this is that they might report they're going to the toilet a lot, but only passing small volumes of urine. When they get to the toilet, they might be having difficulty starting the flow. They could report that it's a really weak flow as well. They might have to feel like they're really straining to empty the bladder. They might also just have the sensation that they're not emptying the bladder properly as well. Some people might find that they dribble after voiding. You know, they might say, I've had a few people say that they've gone to the toilet, they thought they'd finished, but then they stand up and they dribble quite a lot after that. For other people, some people, if their sensation's affected, they might just not be feeling that their bladder is filling up. So when they do go to the toilet, they pee quite a big volume, but they weren't really aware that there was that much urine in their bladder. Some people might also constantly just leak urine, and this is just where the volume in the bladder's got so big that it overcomes the pressure, the closure pressure of the urethra there, and it's coming out. So in terms of what we can do for people with chronic urinary retention. So for those people who aren't getting good sensation that their bladder is filling up, you can talk to them about time voiding. So normally we go about every 3 hours, so suggest that they do that. That you might need to set some timers on their phones, etc., just as a reminder. For other people, we can teach them the relaxed double voiding technique. So first of all, giving them some education around the right position for passing urine. So for both females and males, we're better to sit down on the toilet. That allows the pelvic floor muscles to relax more to help with emptying. Also leaning forward slightly, so resting your hands or your elbows on your knee also puts the bladder in a better position to empty. So you suggest that the person goes to the toilet, they try and keep relaxed as they go, so the belly should be really floppy. And then once they finish that first flow of urine, get them to rock back and forth on the toilet, side to side, maybe stand up a little bit and sit down again, and then have another go at emptying the bladder a second time. For those people that might be finding it difficult to initiate the flow of urine, you could suggest that they turn on a tap if they've got one handy to the toilet, or if they're really struggling to relax the tummy and the pelvic floor muscles, you could suggest that they imagine they're blowing out a candle, like, because that can help to relax those muscles. For men with post-void dribble, you can suggest that they milk the penis once they finish, just to get rid of the last of the urine that's there. The other type of incontinence issue that you might come across with people, and I think this is probably in the community what I see the most of, is urgency. So this is just when people get this sudden desire to pass urine, they can't delay it. It could be accompanied by some loss of urine, it could be small or it could be quite large if the contraction of the bladder is big enough. Some things that can set this off could be just a change in position or a sudden movement. I quite often find people say that, you know, they're lying in bed, they feel fine, but as soon as they sit up, they've got this really strong urge to go to the toilet. Can also be a learned response as well. So you might find some people say when they pull up the driveway, they get the sudden urge, they put the key in the door, hear water running, that can stimulate it as well. With your urgency, it's quite important to just keep in the back of your mind about a urinary tract infection, because they can have similar signs and symptoms. However, someone with a urinary tract infection, they might have some pain or burning as they're passing urine. The urine could be a bit cloudy, or it could have a bit of an odour to it as well. Also important just to think that functional limitations can impact on people's urgency as well. So if, you know, it's taking them ages to get to the toilet, or if their hands aren't working well, or it might be that they just can't communicate the need to go to the toilet. So in terms of management for urgency, so education is a really good place to start. So thinking about fluid intake. So normally we should have about 1.5 to 2 litres of fluid a day if we're not, you know, big exercises or in a really hot environment. What we find quite often with people who are having incontinence issues is that they'll reduce the amount of fluid they're drinking. And what this does, it makes the urine more concentrated, and that can aggravate the bladder or irritate it. On the other hand, if people are drinking really big volumes of fluid, then the bladder is going to fill up a lot quicker. And when it's filling quicker, it can make it more irritated as well. Good to have a discussion with people about bladder irritants. So caffeine is one of the major ones. So, you know, tea, coffee, green tea also has caffeine in it. Other thing is fizzy drinks, and also some of your artificial sweeteners can be irritants. A lot of people get quite panicked when you say, oh, you know, can you stop your morning coffee? But, you know, it's just for 1 or 2 days that they need to try without these things, just to see if it makes a difference to their bladder. And there are good decaf teas and coffees out there too. You want to have a talk about options for products, which we'll talk about a little bit later. And the other really big thing to consider with people with urgency is whether or not they're constipated. If they're constipated, that can put more pressure on the bladder and make it more irritable. Could also discuss medication management with the medical team. Are they on any medications that might be aggravating the urgency? Or if they're really struggling to maintain continence, could you consider an anticholinergic medication? So there are medications that just relax the bladder. You might have heard of oxybutynin and solifenacin before. However, these do have side effects. So you have to pick who these are trialled with. So they can reduce people's cognition, and they also increase people's risk of falls. So can have more harm than good. And then in terms of a more rehabilitative approach for urgency, the aim is to get the bladder back under control. So when people get that sense of urge, they often rush to the toilet. So you want to educate them about not rushing to the toilet. So get them to stop if they can, if there's a chair handy, get them to sit down, because the pressure on the perineal area under there is going to send a message to the brain to say, now's not a good time to pass urine. Also want them to stay really relaxed. If they're tense and tensing their abdominal muscles, that's going to put more pressure on the bladder and wanting it to pass the urine. Get them to keep breathing. Distraction can be helpful as well. So a physical distraction or a cognitive distraction. So a physical one might be that you get them to curl their toes for about 30 seconds. It could be just curling it and holding it for 30 seconds or going on, off with their toes. What this does is it takes up some of those pathways and messages going back to the brain that, you know, you're feeling your feet moving, you're not getting all that information about the sudden need to pass urine. In terms of a cognitive distraction, you could suggest they do some multiplication tables or count backwards from 100 and 3s or 2s for the cognitive side of things. And also pelvic floor exercises alongside this is helpful. Now, it's going to take months of this to make an improvement with people's bladder, so they have to have the time and energy to put into this, and often they may not have that early on after their stroke when they're focusing on, you know, just doing the basic things at home. Products are also important to think about as well because they're likely to have accidents when they do this process. So in terms of your pelvic floor exercises, I found these can be really hard to get people to learn how to contract the pelvic floor. So some cues are really helpful. So for men, you might say, you know, move your nuts to your guts. Other thing could be that get some imagery, get them to imagine that they're walking out into a really cold lake or a river. The cold water's moving up their thighs. They want to pull up the scrotum so that they keep that away from the cold water. For females, you could get them to think about a lift because our pelvic floor muscles work slightly differently. Get them to think about closing the doors of the lift. So pulling in and then you're lifting the lift up, dropping down and opening those doors again. So that could be helpful. Now we want to make sure that we're just isolating the activity to the pelvic floor muscles. So if you felt confident, you could palpate the abdomen and the butt muscles just to make sure that they're not engaging at the same time. If people really can't get their pelvic floor activated using those techniques, you could suggest that they try and stop the flow of urine when they're going to the toilet, just to see if they can get that feeling. We don't want them to be doing that too often though, because it could contribute to urinary retention. If that doesn't help, then your best option is to refer back to the GP, who could refer on possibly to women's health physio here in Canterbury. I'm not sure what other options there are in other places throughout the South Island. Yeah. And in terms of what to do for your pelvic floor muscles, initially people might only be able to hold them for 1 to 2 seconds, but you can build that up with time. So you want to aim for them to be able to do 10 repetitions of 10-second hold if they can. Once they've got the hang of that, you want to progress or vary those contractions. So it's quite helpful then for them to go and do some quick on-off contractions as well, which will help with the stress incontinence that we'll talk about in a minute. There's also a really good app out there called the Nimble app. It's got 2 sides to it. It's got the falls prevention side and it's also got a continence side to it. It's free to access to people over the age of 50. So it's got some really good resources on there and some visuals of doing pelvic floor exercises as well. Other type of incontinence issue you might come across with people is stress incontinence, and this is just where people leak or wet themselves when exerting effort. And it's typically small volumes of urine. So you can encourage people to do the pelvic floor muscle exercises for this. And this is where it's good to do those quicker contractions because you can teach people to quickly activate those pelvic floor muscles before they cough or sneeze to help with that. I often use it as well with people who are finding that they're leaking when they're moving from sitting to standing, is actually build that into your therapy sessions and get them to think about contracting those pelvic floor muscles before they stand up. The other type of continence issue you might come across after stroke is nocturia. So this is just the excessive urination overnight. So what's normal? Well, for elderly, if they're getting up 1 to 2 times at night, that's normal. And for adults, not getting up or getting up once at night is normal. A lot of our stroke clients have fatigue, so if they're getting up a lot at night, then that's really going to impact on their daytime fatigue as well. So in terms of management options, you could talk to them about maybe not having too much in the way of fluids 3 hours before bed. If people are having issues with edema in the legs, you could suggest that they elevate their legs for an hour or two at night before they go to bed, or even try some edema stockings. You could also discuss with the medical team whether diuretics could be used 4 hours before bed to try and offload some of that fluid before they go to bed at night. For females, as the estrogen drops, that can affect their day-night time passing of urine, but also can affect their ability to contract their pelvic floor muscles, so that might be helpful. And of course, discussion around appropriate products to manage that nighttime incontinence. So in terms of products, you want to just make sure people are avoiding the sanitary pads that you get from the supermarket. These don't absorb urine well. They're quite slow to absorb that urine. And you'll tend to get a little bit more odour with these than products that are designed for urinary incontinence, and can also get a bit more skin and irritation as well. So if people are just buying their products from the supermarket, Poise and Tena are quite good brands. There's a wide range to suit the gender and also the level of incontinence, how much fluid they're losing. And then other cheaper options might be your Chemist Warehouse, Bargain, Chemist, Nurse Maud. And I find a lot of people quite like the BL Stringer service as well. It's online and people can order it and they get just a regular delivery. So that can be quite helpful. Other thing to think about for those with leakage is a barrier cream as well, just to look after the skin. So if you've tried these things for a month or two with patients and they're not having any improvement, then refer back to the GP or referral onto a specialist service. So here in Christchurch, we've got the Nurse Maud service for incontinence. Also got the Women's Health team here at Public Hospital that people can be referred onto, or they may need to be referred onto a urologist. So in terms of education resources, there's actually a lot out there. So for those people working within Whakatau, Canterbury, there's a really nice 2-page handout called Bladder Care, and it talks through all the, the normal bladder function, the irritants, the relaxed double voiding technique, and also the bladder retraining. That's really good. Some of these other websites have the information in multiple languages. The Continence New Zealand website's really good. They've got, as Nicky said, it's got a section on stroke and incontinence. They've also got a list of all the suppliers of incontinence products in New Zealand as well, so you can send people there. If you're wanting to do a little bit more education yourself, the Inform Me website's got really good, a good section there on incontinence after stroke. The other good place to look is the Allied Healthways for urinary incontinence in women. It sets out exactly what you need to do with people who are experiencing urinary incontinence. It's really helpful. So I guess the take-home messages would be that, ask people about their incontinence. Don't be afraid to do it. Try and be confident. And then have those caring conversations with people around how it's impacting on their life. And then, in discussion with them, find out what it is they would like. Do they just want to manage it with products, or would they like a rehabilitative approach? So, provide education and information if they want it. And then, refer on if needed. Yeah, any questions?
Wonderful. Thank you, ladies. That was really informative. All the questions that I had thought up just this morning prior to your presentation, you've answered. So, so well done. The audience. You can do it again, pal. Oh, hold on.
Thank you. This is Rosie here again, geriatrician, and that was really awesome. That was such a useful presentation. I was really interested in the bit about the positioning being sitting down for both men and women, because in my head, I've often heard men say they just can't pass urine unless they're standing up. And will often, if somebody's sort of having troubles with retention, we'll often suggest that men try to stand. But I was just interested in your comment that actually for both men and women, sitting and leaning forward is better. I presume that's something that studies have shown, or you guys have success with?
Yeah, from the reading that we've done, it suggests that, and particularly it's around the pelvic floor being able to relax. So, some of our clients, so just standing is quite effortful. It's going to be harder to relax the pelvic floor for that. Yeah.
No one else? No? Okay, so now we're going to break for morning tea. Due to the change in the program, we're now going to be back at 10:40, not 10:50. So just be aware of that 10-minute time difference. So yeah, out there.
Just a housekeeping thing as well. The toilets are out the door and then behind us. And tea and coffee going to be out there.
There's so many Nickies in it.
Here we go. Yeah. Hal? Back stairwell, rest of the building will use front one down here. Disabled person should wait on the stairwell for evacuation by firefighter.
Send your ones out and recommend.
Right.
Last.
Is Nicola here? Yeah, not Nicola's.
Yeah, thanks. It's just coming. Yeah. Yeah. Yes.
So you might just want to tell them in terms of you leave them by the back stairwell
Up
out there,
or here.
and then,
Yep.
and then assembly point is out there. On the
Okay.
back of an ad.
Okay.
So it's
Is
just
that
out.
way? Yeah. Okay.
So-
Cool. So that's if an alarm
Yeah.
goes. Yeah. Cool. And so timing wise, it's 10 minutes early on everything.
Yeah,
Or,
yeah,
Or
yeah.
no. So 10:40, but then this
Oh,
one's
yeah,
still
it should be
11:20.
yeah, it should be, like, put that there, so that's 10:40, and then all the rest should be the same, so, yeah, that's 40 minutes for 40 minutes for Nicola, half an hour for Andrew,
Yep.
and then Nicky. I haven't seen Andrew yet.
And so then finishing for lunch,
Must be the,
10 past, no, 20 past 12.
yeah, 12:20,
Yeah.
yeah.
And so we want people to come back maybe at 1, ready to
yeah,
start.
yeah.
Are you going to do? Hey, how are you? Good, thank you.
Yeah.
Um,
Oh, no, hang on, that's not 12:20, I think that's. Nicky's only got a short.
oh, okay.
Have a drink.
Yes. Yeah, it was if you wanted to like, although you probably don't have, you don't want to circle the brain. In order to do that stuff. Yeah, fabulous. Yeah, yeah. 12, 10. Excellent. There we go. All thank you. I know it's one of my class. You.
presentations, all you need.
Hello. Oh. Kia ora koutou. Can I just get a bit of quiet? Welcome back. Can everyone hear me? Yeah, good. All right. Kia ora, welcome. Ko Emily Timothy Tokawanga. So I am one of the physiotherapists with the Community Stroke Service. I work with Jacqui and Nicky. So it was great to see so many familiar faces. Before we go on, we forgot to tell you about our fire procedure. So if an alarm goes off, there are 2 exit points at the bottom here or the top. So just go to the nearest one and we congregate outside. Hopefully we're not going to need that, but just in case. Now it's a pleasure to be able to introduce to you Nicola Case. She is a professor of rehab and co-director of the AUT Person-Centered Rehabilitation Research Centre. She's got a background in health psychology, and her research draws insights from the intersection between health psychology, disability, and rehabilitation. Her recent research has focused on person-centered rehabilitation, peer support, tele-rehabilitation, and ways of working which build psychosocial resources for recovery and adaptation. Welcome.
Thanks. Kia ora koutou. Thanks, Emily. No ingarangi o ke tūpuna, no tarawhiti Ehau, ko Tamaki Makoto, taku kāinga. I'm responsible for the program change. I flew from Auckland this morning, and thankfully the engineers checked the plane before they departed just to do a triple check, which I would way prefer than something happening in the ear. Ko Nicola K's taku ingoa. Thanks for having me. It's a pleasure to be back here actually. I spoke at this day some years ago now, pre-COVID times. So quite a long time ago, but I think this is just such an awesome initiative, and so it's really nice to have the opportunity to be back here. Sharing responsibilities. All good. And so Emily asked if I would share some insights for our work exploring peer support after brain injury. So my first disclaimer is that this work has been carried out with people with traumatic brain injury, not specific to stroke. But I thought that I would share with you some of the things we've learned, the kind of practical learnings that we've had along the way of trying to stand up a peer support service for people with brain injury that I don't think are diagnostically specific, that I think are relevant to how we think about peer support as a resource for recovery, regardless of the condition that we're working with. But there are parallels as well with the population that we've been working with and stroke in terms of cognition, communication impairment, and how we navigate peer support when people are still grappling with some of those enduring impacts on their life. So hopefully you will see some parallels as we go, and I'm happy to take questions about some of the application to stroke that I see as well. So we started this work. So peer support, I guess the first thing to say is, what is peer support? Peer support is a source of support derived from lived experience or personal experience of something. And when we first set out on this journey, there was a lot of research growing around peer support interventions in a range of chronic health conditions. In some conditions, such as spinal cord injury, we already seen it integrated into routine service provision, but there was very limited research looking at this in traumatic brain injury, and no, that I understood, no services that incorporated peer support into their routine practice. And so we wanted to address that gap in evidence. We started the research quite a long time actually before this trial. I'll tell you some pieces of the puzzle that started before this, but this particular piece of work was we were trying to develop a randomized, pragmatic trial seeking to do two things. First of all, we wanted to provide definitive evidence for peer support after brain injury. There were a lot of skeptics about the capacity of people living with the enduring impact of brain injury and their ability to provide support to others. We wanted to dispel some of those myths. But really importantly, we wanted to gather as much information as we could so that services and funders could draw on that information to underpin future service delivery and provide peer support services as part of our routine practice in Aotearoa, New Zealand. So because of that, we chose a very pragmatic trial design, which as it turns out is really handy when you're running a trial during COVID, where we tried to really stand up services with implementation in mind at the outset rather than setting it up in a super controlled environment. So that's why we have quite a lot of practical learnings along the way as we responded to changes in people and context. So we started this work though back in 2018 with a small feasibility study where we collaborated with ABI Rehabilitation at the time just to test out the idea of peer support after brain injury, and that eventually led to this full trial where we set up services in Auckland, Northland and Tairāwhiti, Gisborne throughout the course of the trial so that we could explore the benefit of peer support in those different regions. We chose those regions really deliberately. First of all, because we really wanted to ensure equity-oriented service provision. We wanted to understand how we access some of those populations in remote settings. In brain injury, which is a little bit different from stroke, we have people kind of shipped to Auckland or Wellington for intensive inpatient brain injury services, so often dislocated from the places that they live, and then discharged back into those remote regions without access to specialist support. So we really wanted to think about how do we provide services for those people that are living in some of those remote regions, and also those regions that have high populations of Māori, as well, living in some of those rural and remote locations that we wanted to provide support for. We ran our first mentor training day in Auckland. So this is for our Auckland mentors in February 2020. So we were all set up, ready to roll, and COVID rolled around the corner. So some of what I tell you about today really was how we responded in that context as well, which kind of highlights to me what's possible in terms of the implementation of peer support. You might start with a vision of this really kind of particular idea of what it could be, and it turns into this, and actually that's okay, it still had benefits for people. We collected quite a lot of data. So we collected a lot of outcomes data, which I'm not really going to focus on today. Alongside that, we spent a lot of time engaging with both our mentors and mentees to understand their experience and what was working well for them. We talked a lot with our mentors about their experiences and what it was like for them. How did they experience the training and support that we put on? And we collected a lot of process data to try and understand, you know, the practical reality of implementing peer support into practice. And so today I'm going to focus on 3 key aspects to share some of our learnings with you. The first is I thought I would talk through what did peer support look like for us? How did we put that into practice? What are some of the things we did along the way to respond to people in context? I'm going to share some of the experiences of peer support with you to give you some insights into how that was experienced by both our mentors and mentees, but also give you some, I guess, tips for future service delivery that we've learnt along the way as well. So first of all, our peer support intervention, what did that look like? So the first thing I would say is that we learned a lot from our feasibility study. So what we did in our trial was very different from what we ultimately did in our feasibility study, because we tested out a range of these intervention parameters to think about what works, what doesn't work in practice. So one of the things that the literature talks quite a lot about is how do we pair mentors and mentees together? What's the right match? What's the right kind of magic between these two people that makes it work? And there's quite a lot of research that proposes that matching people on things like ethnicity and gender and age is really important to that kind of connection and relationship. The reality, though, when you put this into practice, is that you have a limited pool of mentors, and you don't always have the perfect demographic match for the people that are coming through your service who might want to access peer support. So in reality, it's not that easy to match people based on these factors. And so we explored, well, if not matching on demographics, then how do we match people? And there are 2 particular things that were important to how we worked on this. The first is recognise that shared experience of the condition and the experience of living with, in this case, brain injury, or in the case of stroke, trumped everything. It didn't matter whether there were differences in life stage or ethnicity. The thing that trumped everything else was shared experience. So that's the first thing. The second thing is really just taking the time with mentees at the outset to understand, well, what are their preferences? What are their non-negotiables? What are the things that are important for us to understand about them and their perspective that might inform who we match them with? And so really that's where we landed with our matching. In terms of intervention timing in the feasibility study, we started by engaging with people while they were still in the inpatient rehab setting. And we got the mentor to meet with them for the first time there so that they could follow up with them post-discharge into the community. The reality was that didn't work so well in practice either, because People were just so overwhelmed when they first were discharged home. They had a range of other service providers involved. They had appointments coming out of their ears to manage in the community, and they found it really hard to create time and space for that mentoring relationship. So it was quite difficult for our mentors to engage with people. So we had a lot of people who were lost to follow up in that time. So in the trial, we instead recruited mentors up to 6 months post-injury so that people could engage at a time that worked for them. In terms of intervention length, we started in the feasibility study with 6 sessions over 3 months, but that constrained and protracted time period put pressure on people, like they had to have a certain pace of meeting, say, at least every couple of weeks when they were doing 6 sessions over 3 months. The reality is that we missed sessions along the way. Sometimes it was longer between sessions, sometimes closer. Their preference was that we had more sessions, but over a longer period of time to allow for that flexibility to respond to what's going on for people. The last thing that we learned in the feasibility study was we debate a lot about how we could engage whānau in peer support processes. And there were some people who really wanted their whānau involved and others who really didn't. But also it was clear that having whānau as part of that relationship constrained some of the more intimate sharing and reflections and conversation. Most people valued the opportunity to engage with someone who understood their experience but was not their family member, because they didn't want to burden their family member anymore. And so in the end, in the trial design, we said whānau involvement could just be entirely determined by the mentee. So they were welcome if they wanted them engaged, but they didn't have to have them engaged. But we also did offer a session between the mentor and whānau member, so that if the whānau member had questions that they didn't feel able to ask their loved one, but they wanted to unpack with a person who had experienced brain injury, then they could do that. So we learned a lot before we got to the trial about what we could put into practice. And then we learned a whole lot again, partly because of COVID. Partly because you learn as you go, and the benefit of a pragmatic trial is that we could be pragmatic. One of the things we learned quite early is that our peer mentors found it quite stressful to think about this idea of we must have 8 sessions over 6 months, and each session must have a particular purpose, and they're under pressure to build a relationship, to connect with someone, to share their experience, move through this process. So the way we tried to help them navigate that was to think about it more as a menu of possibilities. And so we had kind of 3 broad areas of things that our mentors could do with someone. Getting to know their mentee as a starting point, doing things together in the community, and planning for the future. So planning to end the mentoring relationship was part of what we had to include. But outside of that, they could piece that together however worked for them and the person they were engaging with. So it didn't have to follow a strict format of sessions. It was about being able to respond to the person that they're working with, navigate their relationship with the person in a way that worked for them, and then move on to these other more active things as well when they were ready. And so this menu-based approach worked really well for our mentors. The other thing we learned is that we needed to allow room for different approaches along the way. So we found that each of our mentors took quite a different approach to that mentoring relationship, and that depended on who they were, depended on who the person they were supporting was. It depended on the relationship dynamics or the context in which mentoring was occurring. So all of these factors really tended to influence and shape how they engaged or their approach to mentoring. And we found that no one of these approaches seemed to be better than another. And so a key thing for us is allowing flexibility for different ways of working and valuing different ways of engagement. Whilst we had lots of flexibility in the realities of implementing this peer support process, we, in in our analysis, we have really unpacked what we think might be the 3 key ingredients of the approach we used. And so we would say that be as flexible as you like, but try and retain these 3 key things. So the first is valuing and legitimising lived and shared experience. That was by far the most critical resource that this intervention delivers. So Deborah says here, just having somebody that you didn't have to pretend with, you didn't have to pretend that you were normal and just understood exactly what it was like for you. So that was a critical piece. The second was a connection with purpose. So when we talk about peer support, it's quite easy to minimise what it is, you know, that it's just being a friend. But actually our mentors really were purposeful in planning for and curating the sessions that they had with people. So Marianne says here, I never just whilst in thinking, we'll just see what happens. I definitely prepared for each meeting with her, first thinking about what we would do, and then I would always in my mind have topics that I wanted to ask her about or bring up specific questions that I thought would get her thinking. So they thought quite carefully about what did they talk about in the last session, what might they be trying to support in this next session, how might that, what that might influence in terms of what I ask or what I feel able to share about my own experience with this person that can help settle that context. The third thing that was quite important to the work that we did is that our primary outcome was participation. Like ultimately, we wanted to support people to reintegrate into the community and to participate in meaningful activities. And so we, a key part was encouraging our mentors to do stuff with the people that they were supporting. And so that ranged from playing a game of chess at home with someone, to walking along the beach with someone, to taking them to a local cafe, to riding on a bus with them to work. Whatever that was determined by the mentor and the mentee and was largely about what was important to the mentee. But that connecting through doing changed the way that people engage. So it's really different sharing the most intimate parts of yourself to someone when you're sitting across a table from them face to face, looking them in the eye. You're walking along the beach having the same conversation, totally different context. So it just enabled a different way of engaging, but also built confidence in our mentees to be out in the world and in the community as well. The other thing we thought quite carefully about was how we trained our mentors and how we supported them in their role. And the key thing that we made a decision about really early in this project was that first and foremost, we didn't want to train people or tell them about brain injury. We wanted to value and legitimise their lived experience as the critical resource and skill and experience that they already have. And so our role in training was not to tell them what to do or to tell them about brain injury, but to help them use the skill and experience that already resided within them by virtue of having had a brain injury. And so our training was much more focused on working with them to workshop. We had sessions like sharing your story so that they could practice and they could think about what is their story of brain injury. They could practice sharing their story with other people, and they could have a think about what parts of their story they felt comfortable sharing, but what parts of their story maybe they felt more guarded with. And that did 2 things. A, it gave them a chance to get a feel for what it might be like to do that in practice. But also, it meant they heard everyone else's stories. And so they heard that their experiences was an experience, but not the only experience of brain injury. By really valuing and legitimising people's lived experience. So we had sessions like, well, what do you think a peer mentor is? What if you had had a peer mentor when you were early in your brain injury, what would you have valued? What would you have hated that you wouldn't want a peer mentor to do? And so we built what peer mentoring was from their experience and their wisdom. And that built confidence in their existing skills and knowledge.
We then integrated what we learned from them in the training programs into our training manual. And each time we engage with new mentors in the training program, we cumulatively added to that training manual so that people kept learning from each other's experiences. The other thing we did is we, throughout the process, so every 3 to 6 months, we brought all of our peer mentors together so that they could share their experiences of what it was like to engage with people once they'd had the opportunity to do so. And they could share their experience, they can problem solve together the things that weren't working so well for them. The other thing we did, and this was definitely because of COVID, we started off with this idea that we would have 2 full days training, and like we'd do one week and then do another the week later with people. The topics here are some of the topics I've just spoken to you about. But once we moved into a COVID context, we had to really think about what training could look like without necessarily having to bring people together. And so we delivered training online, and we did much smaller sessions because it was harder to have people engaged for a full day online. So we did much shorter sessions. We really focused in on the key topics that we wanted to make sure we covered with people. And then as we moved through the training, as we had some experienced mentors coming through, they joined the training and became part of the facilitating team as well. We got really good at working out how to do kind of post-it note sessions and things like that online with our people as well. So I guess that just offers you some insights into how we put peer support into practice and how we worked to train and support the people that we were working with. And I thought it would be good to kind of share some of the experiences of peer support just to give you some insight into what it was like for both the mentors and mentees. So this is a peer of one of our mentors and mentees who worked together in Auckland. So Tom was the mentor here. These are pseudonyms, not their real names. Tom is a mentor. He would have been early 20s when he first started working with us, had experienced a severe brain injury, was maybe 18 months post injury when we first engaged with him. He didn't have a job. He hadn't gone back to work since his brain injury. He had been doing some volunteering work at a local gym, and also for a neuro rehab clinic, he was doing some health coaching with them, and that's how he came to be known to us actually. And you can see here, he says, can't read the full thing, but I think he talks about basically post the trial, he ended up moving to New Plymouth. He got a job in New Plymouth in a health role. I can't remember the role. It might have been an audiology type. Oh, here he says hearing therapist trainee. And he said he really feels that the only reason he got the job is because he was able to put on his CV that he had taken on this role as peer mentor, and the experiences that he had was working with different people in the community, engaging with them in the community was what got him that job and made his CV look valuable to the people in New Plymouth. And so for him, like, this was a transformative part of his recovery, and he was the mentor in this case. He was one of our, you shouldn't have favourites, right? But he's one of my favourite mentors. He ended up engaging with at least 3 different people. And one of the people he engaged with was this young man named Mark. Now, Mark had severe aphasia. His mum is the person who's contributing this particular comment. He had not communicated with any other people his age since his injury. His mum was really hesitant for him to engage in the mentoring process at all because she was super worried that all it would do is give him false hope and set him up for a negative experience. But this is one of her comments when we interviewed the family at the end, and she said, I think for the first time Mark interacted with somebody as often and to the depth since his accident, someone outside their family circle, someone who could actually understand and perhaps communicate with Mark in the way Mark could understand. It was fascinating watching the interaction between the two. So Mark couldn't communicate really at all, and like other than with very small kind of verbalizations that didn't really string together well, Tom found a way to work with him. And part of that was connecting through doing. So they did stuff together rather than also relying on that kind of talking relationship as well. Karen here was one of our mentors down in Gisborne, Tairāwhiti, Gisborne. She also had had a severe injury. She was super anxious. So she was really keen to do mentoring. But when we got to the point of matching her with someone, she lost all confidence and was really anxious about the whole experience. And because of COVID, there'd been a time lapse between the training and her being able to be matched with someone. So she was also feeling that distance. And she said, okay, I'm going to do one session, but if it's not working for me, that's it. I'm not doing any more. And there's this really great quote from her where she says, and I went in that room and it was like, boom. Like we connected immediately. She had this really great kind of moment. And she said the confidence building for her to know that she still got some skills from her previous life. So she was a midwife pre-injury, and she had felt that she had lost all of her ability to kind of care for, connect with people in that way. But she's like, it kind of blew me sideways, I think. I was just really efficient and effective. My experience and my strength and being able to share that with somebody was like, for them to be so absorbent and for it to have such a miracle effect was just wow, like seriously. So again, a really enormous impact for the mentor. Deborah, the person who she was mentoring, was actually a woman with mild traumatic brain injury. And so we didn't originally think that we would include people with mild TBI, but we had so many people coming to us with mild TBI with persistent difficulties that we expanded our inclusion criteria to include them. We were struggling with recruitment anyway, so it was good for us. Thank you. And so we did include people with mild TBI, and we weren't sure whether it would have the same kind of impact for them, but it absolutely did. So Deborah says here, she used to talk about just having to make a new life, stepping over the line and saying, okay, this is my new life, and I'm going to go with it. And I was definitely not in that space when I met her. I was still struggling to get back to my normal life. But after being with her, I've actually started a new life. I feel as though I'm forging a new path. She never pushed it. She never ever said you should do this or you should do that. She just talked and just listened. The last example is from two of our peer in Northland. So Ben came to us as a mentor. He came to us first because he was struggling and he wanted to access peer support. And he fell outside of our inclusion criteria when you're running a research trial. He fell outside of our inclusion criteria to be a mentee. And so we kind of had a chat to him and said, have you thought about the possibility of being a mentor? And he was just like, what could I possibly offer anyone? I'm struggling myself. But you can see here, by the time he got to the end, he ended up mentoring about 3 people. And he said, having done it and felt like I completed it too, and I made a difference, I actually feel good about it. I'm getting a bit emotional, but it's been huge for me in my recovery, even like it sort of gave me a sense of purpose. So I certainly felt valued. So it was the first time in his recovery journey where someone had seen something in him that he could offer and that his experience meant something to someone else. Michael, on the other hand, didn't want peer support. When the service coordinator proposed the possibility of him accessing peer support, he was like, well, what would I do that for? What is it? I don't really understand it, but I just went along with it anyway, is kind of the quote. And there's a quote from him later that says this. But then it was so impactful for him. He says, well, certainly works. In fact, I probably would have left my job by now, to be honest. Ben was the one who told me, hey, look, you're only you. This is you now. Do the best you can do with it. You're not going to be as good as you were before, but just run with it. And what you've got now, you're good enough now. And so it kind of made him feel okay about modifying how he did his work rather than leaving work. So just 3 examples all of which really show both the benefit for mentors and mentees was quite extraordinary and wide-reaching for them. Okay, last couple of points and then I'll finish. So I just wanted to finish by sharing some things that we've learned about service delivery along the way, some of which I've touched on already. So the first is let go of the right match. So you don't necessarily need to match on demographics. Probably the two key things was definitely shared experience above all else. But the other thing was, in some cases, being at the same kind of life stage made a difference to how people connected as well. The second thing is make no assumptions about who could benefit from peer support. So there were two things in particular that we made assumptions about in the early stages. First of all, we really set this trial up for moderate to severe traumatic brain injury, but actually people with mild TBI and persistent difficulties benefited equally from the peer support process. The second thing is that one of our inclusion criteria was, must have sufficient communication capacity to be able to participate in a mentoring relationship. Mark's experience, as you can see, this is the same quote as before from his mum, is that what constitutes sufficient communication capacity for them is different than what it might have been for me if I was trying to put that yardstick down. So it was absolutely possible for someone with severe aphasia to engage in this process meaningfully in a way that benefited them. Third, we need to find ways to open up the possibility for peer support. So Michael at Northland, this is his quote here, I went along with it. He really did not think that peer support was for him. He couldn't imagine that he could benefit from it. And he just kind of went along with it because he wanted to kind of do something good for someone else. But he was deeply impacted in a beneficial way by that process. And so how do we help people see the possibility of peer support for them if it's not something that's immediately obvious to them? Fourth, how do we optimize access to peer support? So our biggest challenge was recruiting people to engage as mentees. There's a few reasons for that. It's a research trial, so people engage in a research trial in different ways from what they do in routine service delivery. But we found a couple of other patterns. So for example, when people were discharged back from inpatient services into the community, we lost a lot of people. We knew that there were people living with brain injury, for example, in Tairāwhiti, Gisborne, who would have absolutely benefited, but they never heard about the program because they are lost somewhere in the community and we don't know where they are or how to access them. So how do we have better referral pathways and continuity between these inpatient residential settings and community, particularly in our rural and remote regions? The other thing we had was we relied heavily on our community rehab providers to refer to us, but we know that many made assumptions around who could benefit, around whether they should have access to peer support, around whether it was the right time for them. I think peer support should be available to everyone. And so how do we embed it into our routine service delivery? How do we have clear referral pathways? How do we legitimise it as a resource for recovery that complements our formal service provision? And so I'm going to leave it there. These are my kind of key take homes from each of those component parts. So flex to respond to people in context, but maintain those key ingredients, particularly value living in a shared experience. Recognise the reciprocal benefit. This is not just a service for the mentee, but also for the mentor. Potentially addresses outcomes that our current service provision don't address very well, particularly those psychosocial outcomes, and also vocational outcomes were a key thread that came through that we didn't necessarily anticipate. Make no assumptions around who can benefit. Value peer support as a key resource for recovery, and take steps to integrate peer support into routine service provision. And that's me. Oh, I haven't left much time for questions,
Thank
sorry.
you so much, Nicola. No, that was an amazing presentation. I really enjoyed hearing it.
Cool.
Are there any questions in the audience? Just, oh,
Who's getting good exercise?
Hi, I'm Catherine from Dunstan Hospital. I'm interested to know, is this program continuing, and if so, how is it funded? And what is the cost actually of setting something up like this? What are you paying for?
Great question. So it's not running at the moment, but we're developing a service framework, and we're really trying to engage with ACC on contracting for this kind of thing. That's maybe a long road to hoe, but that's what we're gunning for. In the meantime, I think that every service can probably think about how to incorporate peer support into their routine service provision. The catch is that we did pay our mentors because we wanted to legitimise that experience and we didn't want to take it for granted. So that's, I think that's the main cost for integrating it into practice. And of course, the other cost for us was providing the training and support functions and being available for debriefing. We had a service coordinator in each location who kept in close contact with our mentors to make sure they were well supported. And so having kind of a champion who can be that go-to person for them is probably a key thing. We're still doing some of the economic evaluation side of things, so I can give you a better answer to that once the analysis is done.
Oh, kia ora. Teresa Butler, Rangahaura Māori Build Hospital. What consultation did you have with the Māori and Pacific community?
So so our Northland service was embedded within Te Heke Hauora, which is a kaupapa Māori service in Northland. And so we worked closely with them to determine the best way to stand up a service in their region, for example. And so one of the things that we made a decision for, originally we had planned to employ service coordinators, say by AUT, and then kind of have them embedded in the region to deliver the work. But actually, once we talked to them, they said that's not going to work. They have to be embedded in our service. And so instead, we set up a subcontract with them. They employed the person that was right for them in their community. And then we gave them the money to make it happen, if you know what I mean. So we so we engaged within those localities particularly.
And what feedback did you get from our Māori and Pacific whānau using your service?
I mean, I didn't even put ethnicity on this. We didn't get as many, we probably had more Māori and Pacific. Well, we actually hardly had any Pacific, but we had Māori mentors. We had more Māori mentors than we had Māori mentees engage in the process. So one of the things that we really want to unpack is why that might be. In Tairāwhiti, Gisborne, we worked with people up the coast, but it was quite hard to, like one of our mentees was a young woman who had lived in Tokumaru Bay and she was amazing. She never got the opportunity to mentor someone because we didn't end up with the numbers of people to engage at that time. So there's kind of a lot of work to unpack about actually how we access different communities.
any last questions? No? Okay, thank you so
Thank
much, Nicola.
Oh.
Okay, next up, it's a pleasure to be able to welcome Andrew Sidwell. So Andrew is a general physician and geriatrician working in Christchurch with an interest in stroke care. He has a long-standing input into the acute stroke care in Christchurch and is one of the physicians involved in running the acute stroke unit at Christchurch Hospital. He's also a member of the acute stroke quality team in Christchurch. Welcome, Andrew.
So just to advance slides.
Arrows?
Okay, great. Excellent. Can everybody hear me okay? Great, excellent. So yes, I'm Andrew Sidwell, one of the acute physicians here. So I've been asked to talk on blood pressure management after stroke, both sort of in the acute and long-term phases. Certainly, predominantly my talk's very much more the acute phase, but I do have a little bit about more long-term management of blood pressure at the end. So in terms of, what I'm going to cover in my talk is really, firstly, just brief talk about, is treating hypertension acutely post-stroke a good thing to do? And then I'm just going to go back a bit and talk about some of the underlying pathophysiology and physiology involved in cerebral perfusion, and then really looking at, how we manage blood pressure in ischemic stroke, hemorrhagic stroke, what we do about restarting blood pressure medications, and then, as I say, a bit at the end regarding long-term management. So hypertension and acute stroke is bad, and should we treat it urgently? Is the first question I pose. I guess we're sort of probably all taught, even, lay people in the community, is that hypertension is bad and that we need to treat it. But what about an acute stroke? Certainly in other areas of acute medicine, when people are in hospital, it's becoming apparent that actually treating hypertension in hospital is not necessarily a good thing to do. So in stroke, that's also been one of the questions. And so just as an example, one area that this has been looked at is really trying to treat hypertension very early in a stroke. And so there's been a few studies that have been done that have been in the pre-hospital phase. And so this is probably the most recent and largest of those is the INTERACT-4 study from China, where they enrolled over 2,000 stroke patients. And basically they were assessed in the ambulance using the FAST score if they were hypertensive, which was over 150 systolic, and they were able to treat them with it within 2 hours of symptom onset, they were potentially enrolled in that study. And so they were treated with an intravenous agent. We don't have it available here, but it's somewhat similar to, say, labetalol. And ultimately, they enrolled 2,000 patients. Their blood pressure was elevated, so hypertensive at 178 on average. But what's different to probably our population is they had a very high rate of hemorrhagic stroke, nearly 50%, which is known in Asian populations to have a higher bleed rate, whereas here it's probably more around the 20% mark. Certainly their treatment was effective. When they arrived at hospital, their blood pressure was probably just over 10 millimeters of mercury lower in the treated group compared to the control group. So far, so good. But ultimately, did it make any difference? And so just in the undifferentiated group, so this is all patients lumped together. I'm not sure how familiar people are with the modified Rankin, but it's really looking at somebody's functional state. And as I say, at this stage, it's at 90 days. And this is certainly what most stroke studies really look at, is really that functional recovery side of things. So 0 is really where somebody is completely asymptomatic, completely independent. 6 is that they're dead. 0 to 2 is generally considered a good outcome. 3 is somewhat intermediate, and then 4 to 6 is generally a bad outcome. What this showed is that with everybody involved, the outcome was really neutral. Really, people didn't improve or weren't made worse. However, given that half were roughly hemorrhagic strokes, they sort of looked at the two groups. And what this really showed is that there's a dichotomy of outcomes in the two groups. And so with ischemic stroke, you'll see that in the intervention group, that there are actually less people in the good outcome groups compared to the usual care, the ones that didn't get that blood pressure treatment. So seemingly doing worse if you had blood pressure lowered in the ischemic stroke. Whereas in the hemorrhagic stroke, it was really the opposite, that the ones that had the higher numbers in the better groups were the ones that did receive treatment. So what does that mean? So really currently, in terms of that pre-hospital side of things, that with undifferentiated strokes, basically acute blood pressure treatment is not recommended. Even though it does result in lower blood pressures at presentation, there was this difference in terms of outcomes. And so people with hemorrhagic strokes tended to have a 25% less chance of doing worse, and ischemic strokes, about a 30% chance of doing worse. So why is this? And I guess what I want to come back to is just really starting to talk about, well, how does our brain sort of control its circulation in general? And so there's this phenomena that we've labeled normal cerebral autoregulation, which is really about how the brain maintains cerebral blood flow. And that's really despite fluctuations in blood pressure and is really there to try and, one, prevent ischemia from low blood pressures, but also to try and preserve brain function when blood pressures are getting higher. And in general, this can maintain a relatively stable blood flow, with a mean arterial blood pressure between about 50 and 150 millimeters of mercury. So quite a reasonably wide range. Outside of those parameters, so less than 50 or over than 150, it does become more, flow is more related on the pressure. And so certainly, with lower pressures, you can get cerebral ischemia starting to occur if you're getting those mean arterial blood pressures lower than that. Also in the setting of somebody who's got chronic hypertension, that level tends to shift to the right, and I'll demonstrate that here. So you look at this graph, it's a bit of an over sort of exaggeration and simplification of what happens. But you'll see that in this group here, which is what I've been talking about, is that there's this relatively flat line of cerebral blood flow between those blood pressures. And then if somebody becomes chronically hypertensive, that moves to the right. In some ways that protects against high blood pressures, but equally if their blood pressure was to drop into what would normally be tolerated, you run the risk of potentially underperfusing the brain. How does the brain do this? It really relates to sort of modifying vasoconstriction and vasodilatation in the blood vessels of the brain. And there are a number of things that contribute to that. So some of it's neurogenic, so related to the autonomic system. So both sympathetic and parasympathetic activity will modify cerebral blood flow. There's also what we call metabolic demand matching. So the parts of the brain that are busy and active and using up nutrients and need more blood flow, so their CO2 will go up, they'll drop their oxygens and the pH will drop lower, and that will increase cerebral blood flow, and the reverse will reduce it. And there's other factors to do with the linings of the blood vessels in terms of endothelial factors that can also affect the cerebral autoregulation. So it's very complicated. I can't say that I fully understand it all, but so what happens in acute stroke? And so I guess what we do know is that when people come in with an acute stroke, that probably 3/4 of those people are hypertensive. And this is partly related to sort of background, either untreated or undertreated hypertension. But there's also the factor of the hypertension is really a response to what's going on with the acute stroke, and it's usually multifactorial. So there's a number of hormonal things, including sympathetic stimulation, that can contribute to that. There's baroreceptor dysfunction, so carotid artery baroreceptors can be infected, increased intracranial pressure, and then just the pain and stress of being in hospital having a stroke can be all factors that can contribute to higher than what's probably normal for that person's blood pressure. And what we know is that if we don't do anything, that will gradually settle over time to probably what's more approaching their baseline over a week or so. So ultimately, in acute ischemic stroke, certainly, we know that cerebral autoregulation doesn't work normally. And so the blood flow actually becomes much more dependent on the underlying pressures themselves. And so one of the concerns is really if we drop blood pressure too much, are we affecting that blood supply to that penumbral area around the core of the stroke and potentially making the stroke worse? Because often that penumbral area is reliable on sort of collateral flow, which is generally under, through smaller vessels, and so potentially is needing higher flow, higher pressures to actually get it through to that vulnerable tissue. Equally, higher blood flow, higher blood pressure, because the concern is about leading to hyperperfusion and that associated edema and hemorrhage that might go along with that. So really the goal in ischemic stroke is really blood pressure management is therefore to try and limit the stroke severity from hyperperfusion without causing harm through cerebral hypoperfusion, and really optimizing that longer term functional recovery. So really our guidelines from the Australian New Zealand Clinical Guidelines for Stroke. So basically, I've just summarised the blood pressure one. So it's really that all acute stroke should have their blood pressure closely monitored in the first 48 hours. Patients with acute ischemic stroke eligible for treatment with intravenous thrombolysis or clot retrieval should have their blood pressure reduced to below 185 on 110 before treatment and in the first 24 hours after treatment. So that number was really sort of came about from the studies that were done on thrombolysis initially. That was the sort of the blood pressure that they came up with going into the studies that they felt was probably an appropriate level that would be safe from the concern of causing intracranial hemorrhage through thrombolysis if blood pressures were higher. Obviously, this guideline refers to the fact that you can potentially reduce blood pressure to get below that 185 to enable you to thrombolyse. There's possibly starting to be some evidence suggesting that may not be a good idea. There is a recent trial that looked at that possibly suggested that actually if you try and lower blood pressure and thrombolyse, that those people may possibly do worse than the people that if you just either let them naturally get below that level and thrombolyse, or they end up not getting thrombolysed at all, that they may actually do better than if you tried to lower it. But that's something that's going to be sort of become clearer with time. There's also the evidence that really once you've thrombolysed is really just keeping blood pressure around or a bit lower than that level is really the appropriate thing to do currently. There have been trials that looked at whether do you even try to get it even lower than that after they've had their vessel opened again. And once again, the evidence is they probably do harm if you try to lower it further than that. Otherwise, people who don't get reperfusion treatment, really, our goal is really just to monitor blood pressure really. And it's only if it's really getting over 220, and I'd probably say consistently, that you might start thinking about cautiously trying to reduce that blood pressure. And certainly they do comment on that certainly intensive blood pressure lowering in the acute phase is not recommended. I'll just mention a couple of areas just regarding sort of evolving areas in acute stroke that may sort of become something that we do more in time. One is induced hypertension. So this is really the opposite of what I've just been talking about. And so it's really where we go about actively trying to increase blood pressure, usually through inotropes to actually improve cerebral blood flow. And it might theoretically have uses, particularly if somebody was systemically hypotensive, but also if they've got areas of stenosis such as carotid or intracranial stenoses to try and improve circulation to what might be a tenuous area of circulation. And so there's been some 3 small studies that have suggested if it's done within 24 hours of onset and goes for at least 24 hours that you're targeting a blood pressure of around 150 to 180, that may be beneficial. So this is something that may become part of practice in the future. I guess we just wait to see. Another area that seems to be of interest is that blood pressure variability. So that's really the fluctuation in the systolic blood pressure. And so if somebody's got a highly fluctuating systolic blood pressure, that is generally known to be associated with poorer outcome. What we don't know is if we try and modify that by trying to smooth off blood pressures and how you would try and do that, would that make any difference? But that may be something that we think about in the future. I guess moving on to hemorrhage. So once again here that we're trying to balance, the high blood pressure being the driving force for hematoma expansion, so making the bleeding getting worse. This predominantly occurs in the first 3 hours after a bleed starts. Can go to 3 to 6 hours. And on the other side of that is really trying to once again adversely affect that cerebral perfusion and cause underperfusion if we're too aggressive with our blood pressure management. So once again, it's really trying to limit stroke severity without causing harm through hypoperfusion. So it's a bit like you've got a burst pipe is really what's happening in a hemorrhagic stroke. Obviously, the size of the pipe probably depends on the size of the bleed to some extent. And so what we want to do, we need to reduce the pressure to try and limit the size of the puddle, and which is really what the underlying hematoma is. But obviously, unlike your garden tap, you can't turn off the pressure altogether. We need to allow some flow to keep going through to actually get blood to the brain that's needing it. So coming on to our guidelines for hemorrhagic stroke here. So early blood pressure lowering should be undertaken with a target systolic blood pressure of 130 to 140 within 1 hour of commencing treatment. The reality is that we generally don't achieve it that quickly. And I think one of the keys to this guideline is, I think what's becoming very apparent is that we do, I think we need to start bringing in the term time as brain for hemorrhagic stroke, just as we do for ischemic stroke. Because what the evidence is starting to show is really it needs to be really treatment within probably a couple of hours of the hemorrhage starting is really when you potentially will start getting some benefit, and trying to get it down to that really around about 140 level is the key. But it's really that very early treatment is what is important. And then trying to maintain that sort of level over the next 24 hours is the ideal. Having said that, we also need to be careful that we don't do over rapid lowering of blood pressure as well. And certainly if you've got high drops in blood pressure, if somebody was very high to start with, that can be associated with a poorer outcome. And so probably the better target is to try and do it somewhat gradually, but sort of, dropping that 30 to 45 millimeters over an hour rather than higher numbers. And then, as I mentioned, trying to have a more stable blood pressure during that first 24 hours is really associated with less hematoma growth and neurological deterioration and better functional recovery at 90 days. It does seem that probably the patient group that potentially benefit most in this are often the ones that are more probably in that sort of moderate stroke size rather than the small strokes or the large strokes. And as I say, getting that sort of treatment very much within that first 2 hours. This is just a sort of a different type of graph looking at that, really demonstrating that if you can get blood pressure under good control and maintain it over that first 24 hours, that you do get some somewhat marginal benefit in terms of that modified Rankin mortality rate and maybe the hematoma growth, but it is pretty marginal. And I guess that's what a lot of the evidence for this is actually not that great in terms of really trying to be aggressive with blood pressure management. It's probably sort of somewhat subtle. In terms of what do you use? Basically, there's no evidence. And so I guess certainly what we tend to use here is very much sort of labetalol would be our first line agent, and certainly beta blocker, alpha blockers are probably quite good because of a lot of the sympathetic drive that is going on in an acute stroke process. Otherwise, things like hydralazine can be useful. In some ways, nicardamine would be quite nice, but it's not something that we have available for us. GTN patches are an interesting one. We have been using them, but probably not very acutely. But there is some evidence, particularly in the very acute phase, when they were used in the pre-hospital ambulance state, that they actually were potentially harmful. So I think GTN patches probably are certainly not first line, and certainly would not want to be introducing them too soon into the hypertension treatment. How long do we do it for? Once again, this is really unknown. Some of the studies that were looking at blood pressure went for 7 days. Another one went for just 24 hours. Probably the general feeling is maybe 24 to 72 hours, but certainly after 24 hours, we should really be starting to introduce oral and nasogastric antihypertensive medications and really moving away from that intravenous therapy. I think often we sort of get locked into treating far too long from that point of view. And I think probably even if you haven't got ideal blood pressure control at that stage, you've got through that period where the hematoma expansion is going to have occurred. Just moving on to sort of when might you start the usual antihypertensive medications. There's not a lot of evidence here. There have been a couple of randomized controlled trials that looked at that, and they randomized within 48 hours of stroke onset, and really didn't really find a lot of difference in general as to whether you delayed restarting or you started immediately. However, when they looked at the subgroup of that were the ones that restarted very early after stroke, that they're ones that actually probably did harm. And so probably the pragmatic approach is not to necessarily rush restarting antihypertensive medications, maybe just once they're able to swallow, or if they've got a nasogastric tube in situ. But I think you also just need to sort of weigh it up against what is their blood pressure at the time, how comorbid and frail are they, and in some ways, particularly in ischemic stroke, is really erring towards the side of not over-treating blood pressure, whereas in hemorrhagic stroke, you probably may well be more confident about restarting those earlier. In terms of secondary prevention, we certainly know, blood pressure is a major risk in terms of stroke and stroke recurrence, probably contributes to maybe 25% of the risk. We certainly know that people tend to adhere to treatment if we started in hospital before they go home. And probably the target blood pressure varies a little bit depending on the exact issues with that patient, but certainly probably ideally less than 140 on 90. Probably they're having that slightly higher level if there are issues with stenoses within blood vessels that might affect blood flow, which can then cause problems with hypoperfusion. Whereas if they don't have those, then probably even lower target of 130 probably has more benefit, particularly in small vessel disease or the hemorrhagic strokes. But once again, you just also have to look at the patient in front of you. In older, frailer patients, it's very much start low and go slow, and ultimately will have to be guided by what they tolerate. But one of the keys is really, we started in hospital, but it's certainly not urgent. It's really just starting them on that process and really trying to get control of that blood pressure is probably something that we tend to pass on to their GP to work on really over a number of weeks or even months. And so there's a number of classes that are considered appropriate for that, and often starting even with 2 antihypertensive medications is probably the way to go there. How do you measure blood pressure? That's always one of the tricky ones. We certainly know that sort of just blood pressures being measured one-off in clinics are not very reliable. Probably only half of blood pressures measured in clinics are probably relatively accurate. Whereas there's quite a high rate of white coat syndrome where there's overestimation of blood pressure. But there's also, a group that have what we have masked hypertension. So they measure relatively normal when in fact their blood pressure is probably on average higher. And so they're not necessarily that reliable, whereas things like home blood pressure monitoring or ambulatory monitoring can be more useful and give you more evidence to sort of try and clarify, what is their usual blood pressure like, if they might have a white coat syndrome or a MAS syndrome or not. So I guess my key message is really just trying to keep them brief. From an ischemic stroke, generally acute lowering of blood pressure is harmful and that we shouldn't be doing it. And that secondary prevention, hypertension should really be managed gradually and initiated in hospital and continued in the community. And then with intracranial hemorrhage, time is brain. And that really most hematoma expansion occurs within the first 3 to 6 hours. And so we really need to be treating very early. And that really that target is around that 140 millimeters of mercury. But once again, you do need to take the patient in front of you into account as well. So I guess what can you do about it? I guess one thing from terms of dealing with patients and families is trying to educate on blood pressure goals. Certainly, I know patients and families can get very stressed about high blood pressure, and particularly in ischemic stroke, I think we can be reassuring them, about that, and that that's not a concern early on in the stroke, and that it is more a long-standing, gradual thing to work on. And then the other thing I think is trying to educate your colleagues, I think particularly about intracranial hemorrhage, really time is brain, and really encouraging that really early antihypertensive treatment. So at this point, I'm really talking about, what's given in the emergency department. Yeah. And so that's my talk. Any questions?
Thank you, Andrew. Just before we go to the room, I just want to remind people online, feel free to put questions in the talk function. Anybody here got a question?
Kia ora, it's Rose here, one of the stroke nurses. In regard to the elevation of the head of the bed, it's 30 degrees, is that still applicable with hemorrhagic strokes?
To be honest, Rose, I've not seen any evidence regarding that. It's not something I've seen really commented in the literature at all. So, yeah, I don't know.
And the other one is about mobilising patients. How soon can we mobilise patients with hemorrhagic strokes and with blood pressures and things like that?
I think it's very much dependent, once again, on the patient in front of you, and obviously this probably the size of the bleed. I think probably within the first 6 hours, probably not a good idea. I think probably keeping them sort of fairly quiet. But if they're otherwise, small bleed, they've got minimal symptoms, their blood pressure is satisfactory, then I think it's reasonable to start mobilising. But once again, your larger ones aren't going to be wanting to mobilise that early anyway. Yeah.
Thank you.
Any other questions? Getting your exercise, Carl.
Steps up.
Step count, yeah.
Hello, I just wanted to ask how effective is labetalol usage after 48 hours of stroke?
So after 48 hours?
Yeah.
So I think probably after 48 hours, we should be moving away from intravenous labetalol and really getting them onto oral or nasogastric, depending on what route they have available. So it'll still be effective, but it just, once again, we should be getting away from the use of intravenous's after 48 hours, yeah. I think really the first 24 hours is really the key for the intravenous treatment, yeah.
Great. Oh, another.
Hi, I'm Brandon. I work in the acute stroke unit. Yeah. So if you look at like IV labetalol boluses, are there any evidence that suggests that having labetalol infusion is better in hemorrhagic stroke because that reduces the systolic blood pressure variability when we are giving bolus pushes?
Yeah, once again, I don't think there's any evidence on that at all, really. As I said, there's not really any evidence regarding what's used. These are just the agents that are used, but it varies from centre to centre in terms of what gets used. But yeah, certainly, you know, I think if the blood pressure variability becomes something that we end up trying to really get on top of, then yes, something like an infusion may well be the way to go with that. Yeah.
Great. Thank you very much, Andrew.
Right.
I appreciate that.
Thank you.
Thank you very much. Okay, and we have our final speaker for this morning, Nicky Mayne. Nicky is the General Manager for Community Services for Stroke Aotearoa, New Zealand. She joined the organisation at the start of 2021 as General Manager for the Te Manawa-Taki region before being promoted through the Recent Change programme. Nicky has a diverse background leading non-for-profit organisations, including as CEO as a disability service provider before joining Stroke Aotearoa. Nicky has regularly presented at trainings and workshops to support those affected by disability, informed by her experiences as both a provider and mother to 2 adult children who live with disability. Thank you, Nicky.
Kia ora. Can everyone hear me? It's so great to be down here. This is kind of a familiar place for me. I lived for 10 years in Kaikoura. So spent plenty of time with my children at Christchurch Hospital. Yeah, so it's nice to actually be back here in a completely different context. So as mentioned, my role is General Manager Community Services. So my team are the community stroke navigators and the return to work advisors all around the country. And just up at the top there, Kirsty and Emily can just stand to their feet. So Kirsty Hamilton is a community stroke navigator for the Canterbury region. And Emily is the team manager that looks after the South Island and the lower North Island. So they've got big areas to cover. So there's been a lot of changes with Stroke Aotearoa in the last 18 months or so, but there's a few things that stay the same. Our vision now is bigger than it probably ever has been before. So our vision is for a stroke-free Aotearoa. Now, we know that that's not going to happen probably in our lifetime, but to be honest, if we don't shoot to the stars, you know, we've got to land at least somewhere higher. Our mission, preventing stroke and improving lives. So we've just released our next 5-year strategy, and our main goals around prevention and awareness, life after stroke, and advocacy. And intermingled with those is being TTDT aligned and being a thriving organisation. So the big visual representation of our change is you'll see that we've got a different brand awareness there, a different name. We're no longer called the Stroke Foundation, we're Stroke Aotearoa New Zealand. And at the core of that is Te Ahi Tūmanako, the flame of hope. So the story is that we were given some money to use for a capital project. and we gave the trustees a couple of different projects that we could do, and they chose our brand awareness one, and to look at who we are and what we did. And so we went out and talked to people. We talked to stroke survivors, we talked to clinicians, we talked to donors, to funders, to all sorts of different people. And what they told us is that we are outdated, that they didn't really know, a lot of people didn't even know who we were or what we did, that we seemed too clinical, seemed too boring, which is all great feedback, right? People were honest. You know, even though we've been doing a lot of work in the last 45 years in New Zealand, you know, stroke rates were still increasing, and people were still feeling like they were missing out, that they weren't getting the support that they needed after stroke as well. And another issue is that we were plugging gaps in the health system. So less than 18% of our income comes from government, and we have to fundraise for the rest. So it's not as if, you know, we've been paid to do any of the work that we've been doing. We're paid very minimally for the work we were doing. So all the work, you know, that we've been busy doing, we were actually just doing for free for the health system, because we knew there was a need, but we couldn't keep doing that. We wouldn't exist now if we hadn't made the changes about 18 months ago that we needed to make. So things needed to change, and we heard from people about what they thought of us. And a reoccurring theme happened in all those conversations. The word hope kept coming up. It was about hope for a better tomorrow. It was a hope that stroke numbers could reduce, the hope that outcomes for stroke could be improved, the hope that in some families that stroke was not inevitable, you know, the hope that, you know, people can still go on and live a good life despite what's happened to them, despite their stroke. So that's where the flame of hope has come from. It's no surprise to you that stroke is a big problem in Aotearoa, New Zealand. So around about 9,000 strokes happen each year, leading cause of adult disability, second leading cause of death. And, you know, I think there's a real equity issue. 60% of strokes for Māori and Pacific people occur at working age. I don't know about you guys, but I don't think that's right. I don't think that's fair, and it's not something that I think we need to, it's definitely something that we need to address. And the problem is that, you know, it's such a big problem that we can't do it alone. Like one organisation like us, one little organisation can't, you know, do this alone. We work with all you good people. We work in the community with other organisations, because this is a problem that can't be ignored. It's costing the country a lot of money, and we want to stop people getting to your doors. If you work in hospital care, we want to stop it getting there, because that money could be spent in better ways, and also the harm and the burden to families could be greatly reduced. So a couple of key roles within Stroke Aotearoa is the Community Stroke Navigator. So Kirsty up there is the local one to here. We only have 12 Kirstys around the country. 9,000 strokes, 12 Kirstys. So it's not as if we can actually be face to face with every single stroke survivor. We just don't have that capacity, and we're not paid to do it, obviously. But what we can do is give easy access to us. We have set up an 0800 number now that anyone can call, 9 till 5 weekdays. You don't need a referral, you can just call us. So if you've got a question, you can call us. And since we've set that up, we've found about a third of the people who call us are stroke survivors, about a third that call us are whānau or carers of stroke survivors, and about a third are people like you, people who work with people affected by stroke, and you have questions so that you can be supporting those people with stroke. So the team, so Kirsty has her rostered days on that 0800 number as well, and yeah, they're there just to provide that instant advice. You don't have to wait, you don't need to worry, you don't need to, you know, fret at all. It just reduces the stress for people. We do a lot of community prevention, education and training and awareness of stroke. So, you know, up to 90% of stroke is preventable. So we really want to work hard. So we're doing more work in prevention now than we were. And part of that is doing a lot of blood pressure and AF testing around the country. So expos, events, workplaces, those sorts of things. particularly trying to reach priority populations. Directing our efforts into the places where we can meet the best populations. We provide support for stroke groups. The peer support is a very important thing, like we heard from Nicola before. Having someone who's had a shared journey, some similarities, not just for the stroke survivor, but carers, whānau members as well. So we provide support to stroke groups around the country. Do a lot of the fast community education. We do life after stroke workshops and life after stroke education sessions for the stroke affected community. So a life after stroke workshop is about 2, 3, 4 hour one-off event where anyone can come and learn and hear from speakers on different topics. Our life after stroke education sessions are just starting to launch at the beginning of next year. It's a series of 5 smaller group education sessions that you can let people know about when they're happening in your community, and this group meets together for 5 months with the hope too that they might actually form their own peer support group afterwards, that they carry on meeting after that as well. But there they can get their questions answered, they can hear from others who have been on the journey with them, and they can get some education. Obviously, life after stroke support and secondary prevention, including a smaller number now of hospital referrals for people who particularly have access barriers. So I'll talk a bit more about referrals a bit later on. We also do Stroke 101 training to lift sector capability and capacity. So our Stroke 101 training is about a 90-minute training, and we work with health coaches, health improvement practitioners, support workers, kaiawhina, those types of workforces who actually see stroke survivors and their carers in everyday life, and we educate them around stroke and how to best support people as well. We also, my team includes return to work advisors with a lot of stroke still happening under the age of 65, which is what MSD considers working age. We can provide return to work support. So really important to refer those to us early if they need some return to work support, so we can make sure we can keep their jobs open for them, like work with their employer with them, and give them their best chance of returning to sustainable work. Working on other things as well, so increased access. We're increasing support to Māori. We're working with iwi Māori partnership boards where we can. Lots of hauora providers, lots of kaupapa Māori providers in particular, and Pacifica organisations, trying to work with them because they can reach their communities way better than we can reach them. So if we can reach them and work with them and educate and support and collaborate with them, then they are the ones that will be taking the messages out to their communities. We're developing an NZQA Level 3 certificate in long-term conditions. So that is with Heart Foundation, Diabetes New Zealand and Arthritis New Zealand. So we are working with them. So there's a Level 3 NZQA certificate, particularly aimed for support workers, HIPS, health coaches, kaiawhina, those types of workforces as well. Doing a lot of work in advocacy, meeting with ministers, doing submissions, that sort of thing. We've got some big goals, and so we have to do some real hard advocacy around it. We've got a lot of online resources. Seriously, as stroke survivors become more, the new generations coming through more able to access the online types of resources, or their whānau members can. You can just head along to our website. You can download resources. You can email them to people. You can do whatever. You can print them. You can show people how to access the information they need. So you can just go to our resource hub or just search for something that you're looking for. We also have lots of events that we advertise. So if we're having a Life After Stroke workshop or anything like that, we'll put that on our events page. That's where all the stroke groups that are affiliated with us are listed as well. And one thing that you can use is that we do a monthly online stroke cafe for people particularly who can't get to a stroke group, and we keep the recordings of those topics, so with key topics, and we keep the recordings on our website so they can be accessed at any time. We don't get a lot of people in on the live sessions, but we get hundreds of downloads of the video over time. There really is just a lot of stuff on our website. If you're going to give anyone any sort of printed information, it's this one, support available after stroke. Essentially, it's a signpost to try and help people to know where to go and how to find the support that they need once they've left hospital. And of course, if they're in work, the return to work one as well. You can order resources through Vertia. Resources are free. Those are just some of the resources that we have printed and online available. I've got a bit of a selection out in the foyer there you can look at over lunchtime as well. And referrals, talking a little bit more about that. In terms of the return to work referrals, refer early, if you get one message for that one. And in terms of referring to us, I'm a big believer in empowering people that if they can call us, if they're able, they've got family members who can call us, then they should call us. They should be the ones directing the support that they need. But if you're concerned about someone, if you have that concern that people won't reach out and their outcomes will be worse because of it, then please do refer those people, right? So refer people where you're concerned about them, but where they're able or their family member is able, get them to ring us. You know, then they can do it at a time that suits them. They can just reach out, and they can reach out as often as they like, rather than just sitting there waiting for us to give them a call. And that's me.
Thank you, Nicky. Fabulous. Mihi, you guys are all doing. Laura, are there any questions online? No? Okay. And to the audience.
With your return to work, when referring, does the patient already have to have a job, or will you help them to find new work?
Generally, our sweet spot is when people already have work to return to, and that's because we're not a big organisation like WorkBridge. So we have the same contract as those big providers, but because we don't have people out there able to hunt for them. So the only times we will support people is if they're able to do that job hunting themselves, and we can provide them with the additional support of graduated return to work, those types of things. So it's not our sweet spot, but in limited times we will.
Any other questions?
I'm getting away easy by the looks of things.
Thank you so much.
No worries, thank you.
Thank you.